Hello, fellow debaters. My name is Pamela Wood, and I'm here to moderate this debate for you today. Our debate topic is it necessary to standardize evidence-based treatments? Why and why not? Today we have four amazing ladies that will be debating. We have our pro side, which will be Mary and Sarah, and we have our con side, which will be Kirsty and Jessica. Today we are going to start the debate with the pro side from Mary. Each team will have 7 minutes for their debate each time that they present, and they will have signals for when their time is coming up to an end. So let the debate begin, starting with Mary on the pro side.
Hi, my name is Mary Catherine Bugle, and I will be debating on why it is necessary to standardize evidence-based treatments. The 4 points I'm going to make are that it is an ethical responsibility, it will be uniformity across professions, there has been proven success with ABA, and the last point I will be making is replication of findings. So the first point, it is an ethical responsibility to provide highly effective treatments supported by research. There is an ethical obligation to use treatments that have been the most effective results for the clients being treated by the BCBA. According to Compliance Code 2.09a, clients have a right to effective treatment. Behavior analysts have the obligation to advocate for and educate the client about scientifically supported, most effective treatment procedures. Effective treatment procedures have been validated as having both long-term and short-term benefits to clients and society. Also, according to Compliance Code 2.09c, in those instances where more than one scientifically supported treatment have been established, additional factors may be considered in selecting interventions, including but not limited to efficiency and cost effectiveness, risks and side effects of the interventions, client preference, and practitioner experience and training. Ethically, we are required to provide effective treatments. We often utilize treatments found in the National Standards Project, which have been created to give their user a guide of what practices are effective and most appropriate for the clients. The second point is uniformity across all settings involving the client. This could include, but is not limited to, teachers, behaviorists, occupational therapists, etc. All of these different therapies need to follow the same standards, so they are all able to work together for the benefit of the child. All therapists should be using evidence-based treatments and creating a standard list, and that would allow all professionals to use only the most effective evidence-based treatments. Having a standard list would increase collaboration between the various fields, where often there is a disconnect. The Behavior Analyst Certification Board Professional and Ethical Compliance Code for Behavior Analysts states the requirement for the professional certificate holders to uphold certain ethical standards. According to Compliance Code 2.03b, when indicated and professionally appropriate, behavior analysts cooperate with other professionals in a manner that is consistent with the philosophical assumptions and the principles of behavior analysts in order to effectively and appropriately serve their clients. According to Code 2.09a, clients have a right to effective treatment. Behavior analysts always have the obligation to advocate for and educate the client about successfully supported, most effective treatment procedures. Effective treatment procedures have been validated as having both long-term and short-term benefits to clients and society. And finally, for this point, according to Compliance Code 2.09c, in those instances where more than one scientifically supported treatment have been established, additional factors may be considered in selecting interventions, including but not limited to efficiency and cost effectiveness, risks and side effects of the interventions, client preference, and practitioner experience and training. The third point I'm going to make is success within the ABA field. The Behavior Analysts Certification Board have been using a standardized list to pull evidence-based treatments from and research proving the success of those treatments. There are articles targeting a variety of behaviors across several different populations. Within the field of ABA, we have defined what should be targeted and how to monitor and determine what interventions would be used. Our guiding principles follow the 9 dimensions listed by Baer, Wolf, and Risley, and these 7 dimensions are the backbone of ABA. The final point I'm going to make tonight is replication. Once the interventions have been standardized, there would be less wasted time having to consult about methods and interventions that are used in one field versus another. All professionals would have access to the standardized list of evidence-based practices. If the professional has further questions because of the practice may be out of their realm of expertise, then they could consult and specifically ask about a treatment they found in the standardized list. Replication is one of the hallmarks of behavior analysts. If an intervention cannot be replicated and shown to have the same results or a similar trend, then that intervention is not likely to make it into our evidence-based practices. Interventions that have been proven to be effective are the interventions that should be used for children with disabilities. Thank you.
Thank you for your points, Mary, for the pros side. Now that we have heard from the pros side, the four main points from Mary's debate to start us off were ethical responsibility to highly effective treatments, uniformity across settings that involve the client, success with the ABA field, and replication. Now that we've heard those points from Mary, we're going to move to Jessica and Kirsty on the con side, and we're going to listen to their points about why they disagree that evidence-based practices should be standardized. And to start us off, we will have Kirsty, who is going to present her points for us.
Hi everyone, I'm Kirsty Wineland, and I'm on the con argument side. I have 4 points as well, and the first point is limited resources, which includes training, time, finances, language barriers between professions. The second point we have is generalizability. Then the third would be implementation accuracy. And the fourth is devalues and de-emphasizes professionalism and clinical expertise. So first point with the limited resources, in training, it would take an immense amount of time to train and cross-train professionals that have ingrained practices already. So this would include any professional that has already been in the fields. We would have to go and train them additionally. In the second portion of this, which would be time, this is also tied into the training aspect and is the creation of standardized manuals. So this kind of takes away from your everyday differences in ABA, and it causes more of a standard cookbook-like procedure where you would have to look up each intervention and everything is completely basic towards whatever client you're working with. Financial, so the cost of creating a review board and the cost of training persons to implement the intervention additionally would pose as an issue. And also the cost of dissemination. So when we're actually trying to make this work, these types of things are going to cause a financial burden. And then the last point for limited resources is language barriers by professionals. So each profession would be part of the standard manual and would all need to use the same vocabulary. It would be really difficult if ABA professionals were using one vocabulary and then OT, PT, speech teachers were using a different vocabulary and not everybody was on the same page. And not all professionals can identify what a DRO, DRI, DRA, or an FR1 even mean, just to identify some commonly used acronyms with the ABA realm. For there to be a cohesive program, the jargon of each profession would need to be taken into consideration. So the next point is generalizability. And in research, most often, they'll be conducted within a clinical setting. So when interventions are done in these types of settings, you have greater control over the independent variable, but you lose the ability to see the efficacy of the intervention within the natural setting. So the clients and the practitioners are unable to have a generalization within multiple environments. The third point would be implementation accuracy. So we need to ask the question of who is responsible for making sure that people are utilizing the interventions in the way that they were written. There would need to be some sort of considerable protocol for implementation, and someone would have to be responsible for writing that. We would have to figure out, would that be the BACB? Would that be a higher power? How would this all work? And then the final point is devalues and de-emphasizes professionalism and clinical expertise. So this is where we're talking about the standardization of the manual of treatments. And basically, another acronym for this would be like a cookbook-like procedure where one size fits all. All clients are different and all behaviors can be treated in different interventions. So it's tough to say that one intervention can work for a different age client, a different SES client in a low-income area, a different client in a higher income area. So it's all different based on what the behavior is, and we have the freedom to use different interventions in the current model of behavior analysis. So there's a risk that people will pull from the intervention and have little knowledge of how to choose interventions based on functions of behavior. How would we ever come up with new interventions, and who would be responsible for that? That also goes in hand with the implementation accuracy and trying to figure out who will be responsible for utilizing interventions and who's going to write these. So additionally, there are several interventions in the older National Standards Report for Phase 1. And in Phase 1, there are interventions that only qualified as emerging. But now in Phase 2, they're considered established. So that's something we have to consider as well. There are also interventions that are being used and have been used that are in an emerging category still. So would these interventions now become obsolete? Having a manual that houses the only interventions that should be used would also not allow for families to input their opinions and make changes on family dynamic. This could be problematic because it could devalue the culture of the stakeholders and basically pulls the professionalism from the ABA fields. Thanks.
Thank you for your points. We have just heard the 4 points from the con side, which were limited resources, generalizability, implementation accuracy, and the devaluing and de-emphasizing of the professional and clinical expertise. Now it's time to hear the rebuttals from the pro side.
Hi, my name is Sarah Graham, and I am reading for the pro side. We have 9 points, to the pro. We have programs can be tailored to meet individual needs. All plans focus on the individual. Insurance can be affected. Training and cross-training will not take a significant amount of time. It improves implementation. We still need work generalization. It doesn't devalue other professions. It just unites them. Less experimental designs, but more merit in clinic-based settings. Does consider parent values. Those are my points. Okay. Despite the standardization, the programs can still be tailored to meet the client's needs. Standardization does not pick the program to use, but it gives a criteria to make sure they meet the BACB standards. It will also make it easier to choose a plan that will do no or little harm. There is still room for adaptability and using the BCBA's expertise to decide which plans work for their clients. No plan is going to work across the board in every situation for every client. It's the job of the BCBA to figure out which one will work with the best, using the best science. Standardization should make this easier, as BCBA no longer will have to research as much if the science is good. If a plan is repeatable, or if they will be able to implement it effectively. Oh, I'm sorry. Davies, Reichow, and Follett. I'm sorry. Okay, I'll just go on to my next one. All plans should focus on the individual. It is the job of the BCBA to figure out which plan will work with their client. Standardization won't take away from that. It takes away steps in determining the science that can back up their selection. So they will have to do less to do more. Does that make sense? Also, payment and reimbursement can be affected, but it already is affected now. Only 43 states cover autism services. So standardization will mean that they will only accept certain treatment plans. However, they already do this. No insurance accepts all treatment for reimbursement in any field. Not even all states mandate autism services be covered by as of 2015. It is up to the BCBA to work with the client's insurance to come up with the best, most cost-effective treatment plan for the individual, which they already kind of do. It also, it shouldn't take longer to train or cross-train, as BCBAs should already be training their staff in order to meet Ethics Code 504. Standardization should actually streamline the training process by making it consistent and having clear, concise directions that are easily understandable across multiple experience levels. It will actually improve implementation. There's an article by, oh my God, I wrote it down. An article by Stammer that talks about how to use evidence-based practice in implementation. It leaves less room for implementation error because there's a standardized process for how they implement it. So it allows the treatment to speak for itself rather than the competence of the individual implementing it. All plans need to have generalization, so they should be able to still be able to work within a variety of environments, addressing code 407A and 407B, which is environmental conditions. Standardization should actually improve this by allowing more clearly written instructions for what to do in specific environments rather than the BCBA guessing as to what will work. So there's less trial and error. It won't devalue or discredit professional and clinical experience. It allows the science to speak for itself. The plan can be adjusted as the BCBA sees fit, but as it allows for less error in implementation, it means it is less likely that the plan won't work appropriately because someone did not implement it correctly. If it doesn't work, it's because the plan is not working for that particular client rather than someone didn't implement it correctly and a new one actually needs to be selected. The BCBA still has to evaluate and use their expertise and experience to find programs that will work best with the child. It does have less experimental design, however, it allows for it. It allows for it. It just has to be tested and proven to have some merit based on clinical experiments. Just like in the pharmaceutical industry, they don't just put a drug on the market without testing it to see if the good of the drug outweighs the harmful effects from the most number of people. No drug works 100% of the time with 100% of the people. There is no way to determine which drug is best, but it gives the medical professional a list to choose from of the drugs that have limited harmful effects and allows them to pick the best based on their expertise and knowledge of the patient. It does still take into account the patient and parent values combined with 4.02 and 2.05D. Involving the 4.02 is involving the parents in planning. Standardization will require a greater accountability on the part of the staff to implement and choose the most effective plan for the client. It does remove the responsibility to the client, or it doesn't remove the responsibility to the client, but removes some of the steps in evaluating plans and hopefully making it easier to use their input in choosing the plan. So that's it.
All right, thank you, Sarah, for your points. The points Sarah just discussed, I'm going to read them off real quick one more time. The pro rebuttal was, despite the standardization of the programs can still be tailored to meet the client's needs. All plans should focus on the individual. Payments and reimbursements can be affected. It shouldn't take longer to train or cross-train. It will actually improve implementation by making it standardized. All plans still need to have generalization regardless of standardization. It won't devalue or discredit professionalism. It does have less experimental design, however, it allows for it. So there's still that possibility. It does still take into account the patient and parent values. So now we are going to hear from the con rebuttal or attacker, Jessica.
Hi, my name is Jessica Lawless, and I will be discussing the con attacker points. Standardization of evidence-based practices causes us not to be able to individualize treatment to meet each individual client's needs. Standardization of evidence-based practices also causes us to use treatments that only focus on the diagnosis and not on the individual themselves. Standardizing treatments could be influenced by insurance policies and reimbursements. And standardizing evidence-based practices could cause us to leave out treatments that would be effective, especially with specific clients. So for the first point, standardization of evidence-based practices causes us not to be able to individualize treatment to meet each individual client's needs. Even if we were to narrow the evidence-based practices to just those with autism, given there is more research within that area, we are still asking experienced people to take an intervention and make it appropriate for all children. Using a discrete trial training program can either be very structured with no deviation, or it can be combined with a more naturalistic approach. Teachers may be fond of doing more structure in their approach to using this intervention, while an ABA therapist would be more than likely to target this within the natural environment to encourage generalization. Implementers may be biased in their approaches to some interventions regardless of what the standard would show or what the literature actually says about their version. Standardization of evidence-based practices also causes us to use treatments that only focus on the diagnosis and not on the individual themselves. Another issue that could arise is that we might find out a client has been diagnosed with autism, and we immediately assume that the child would need a specific treatment, such as a picture exchange communication system, or PECS. The child could have several maladaptive behaviors, so the teacher automatically thinks he needs PECS to help him communicate, but he could be using some other type of speech-generated device or augmented communication device, or he may be using verbals as his functional communication, but the teacher would automatically assume he needs PECS because he has autism. This can lead to a treatment bias and stereotyping. Third point, standardizing treatments could be influenced by insurance policies and reimbursements. Another issue is who determines standardization of practices. Standardization by a third party, such as legislatures and others outside of the field, such as insurance companies. Those who are determining reimbursement and insurance coverage are the ones standardizing evidence-based practices in most situations, and not an actual professional in the field, which could lead to standardizing evidence-based practices that are truly not best practice for the populations they're being standardized for. The fourth and final point, standardizing evidence-based practices could cause us to leave out treatments that would be effective, especially with specific clients. The issue here is that there are interventions that are not yet proven to be effective, but are being utilized in a daily basis, such as floor time, and these interventions are seen as effective. Teach, for example, is a style of teaching which was on the emerging list back in the first phase of the National Standards Project. This technique continued to be used even though it was only considered as emerging and has been effective for many individuals. If standardizing treatments takes place, then there will be a large amount of unstudied research points because people would only be allowed to use evidence-based treatments based on the manual or cookbook.
Thank you, Jessica, for those points. I'm going to just highlight what she just described real quick. Standardization of evidence-based practice causes us not to be able to individualize treatment to meet individual client needs. Standardization of piece also causes us to use treatments that only focus on the diagnosis and not on the individual themselves. Standardizing treatments could be influenced by insurance policies and reimbursements, and standardizing could cause us to leave out treatments that would otherwise be effective with some of our clients that are not yet proven effective. That was the last rebuttal for our debate for tonight. I want to thank the rest of the fellow debaters who will be presenting eventually for tuning in and listening to our debate in your busy schedule this week. We look forward to your questions and your discussion comments, and we look forward to deepening our knowledge about the subject based on your experiences and your research. Thank you.